Occupational English Test. Listening. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. You hear an ophthalmologist talking to a patient called Dominic de Souza. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Now, Mr. de Souza, I've got your notes here, but I wonder if you could tell me in your own words when you first had problems with your eyes, how the condition developed, what treatment you've had, and anything else you think I should know.
Yes, of course. Well, I've got the usual age-related problems with my eyes. I started getting short-sighted about 5 years ago, soon after I retired, so I had to get glasses for that. But with this latest problem, I realised that my eyes had got much worse quite suddenly. What happened was, I was walking home at dusk one evening. It was getting dark and there wasn't much light, and I suddenly realised that I was struggling to see where I was going. And that wasn't all. I noticed I could see much better out of my right eye than I could out of my left. It was all a bit worrying.
Yes, I see.
I mean, this was quite recently. But after that, my eyesight got worse fairly rapidly. I mean, I was doing some volunteer work for a charity, but I've had to give that up. Well, for the time being, at least.
I see. And you've been to see a local optician?
Yes, I didn't know what else to do. He did some tests and then said he thought he could see what he called drusen at the back of my left eye.
Right.
So he referred me here for further investigation. But he did suggest in the meantime that I should take a preparation that's high in lutein. He also said I should up my levels of green vegetables. Well, that's sensible anyway, so I've done that.
Good.
I was quite worried after that visit, as when I looked online at what he's said, it seemed to suggest I'd got macular degeneration. So that was really frightening.
Well, your optician was right to refer you, and from what you've described, that is a possible diagnosis, but we need to do more tests to see if that is the case or not. So what's the situation now?
Well, I can't see very well using my left eye. Something's definitely wrong there. Like, I find it hard to estimate size. You know, things look smaller with my left eye than they do with my right.
Right.
But apart from that, the area right in the middle is blurred. It's all quite unnerving.
I can imagine. And how's your general vision?
Well, let's think. The optician said that I had no problems with my peripheral vision, and there's been no change in that as far as I can tell.
Right.
And I'm still coping day to day. I mean, I can still manage things like watching TV, which I'm grateful for. But I recently decided I should give up night driving. I just felt my vision wasn't good enough anymore. Actually, I read in the leaflet you sent me that you might want to carry out an angiogram. Is that one of the tests you're thinking of?
One of them, yes.
Could you tell me a bit more about that, please?
Well, it's quite a specialist test. What it would do is allow us to see the back of your eye, and the reason for doing this is to establish whether perhaps your problems are being caused by a blood vessel there, which may be leaking. And it could be that which is affecting your vision.
I see. Another thing I read about is laser surgery. Is that the treatment for that condition? Because I'd be really worried about having that.
Well, we need to do the test first, and anyway, even if that is the cause, this condition can settle by itself. If it doesn't, there are various treatments we can offer. Yes, laser surgery is a possibility, but we're not at that point yet.
I see.
So we'll do the test, but what I'd like to suggest in the meantime are a few things you can do to help your situation.
Extract 2, questions 13 to 24. You hear a neurologist talking to the father of a 9-year-old boy called Tony, who's recently started having seizures. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Mr. Fitzgerald, I understand that Tony's 9 and his seizures started about 6 weeks ago?
Yeah, that's right. The paediatrician was worried because Tony was experiencing what he called episodes of confusion. That's why he recommended this neurological evaluation.
I see. So what happens when Tony has a seizure?
I suppose the first thing we notice is that he gets this kind of vacant look. We didn't understand what was happening at first, why it was that he didn't seem to answer our questions, but he's since told us that he can't. It's like he loses the power of speech altogether. I had a chat with his teachers to see if they'd spotted anything unusual, and they said they'd sometimes noticed the same kind of behaviour at school too. Later, we noticed that his mouth moves. It's as if he was chewing something, but there's nothing there.
Right.
I suppose all that goes on for about a minute or two, and then it takes about 5 minutes or so before he's back to his normal self.
And how is Tony after a seizure?
Well, one thing that struck me was that he hardly remembers anything about it at all. I found that very disconcerting at first. He's told us that he becomes frightened whilst the attacks are happening and that he feels exhausted after. In fact, he often needs to lie down for a bit, and he might even nod off. He also complains about having really bad headaches, though that doesn't happen every time.
And how would you describe Tony's ability to cope with life in general, like at school, for example?
Well, Tony hasn't got any problems at school. He meets the expectations of his teachers, even if he doesn't exceed them. Just your average boy, until now, that is. But he is creative, especially with his writing. In fact, one thing that's slightly unusual about Tony is that he's ambidextrous. It runs in the family on my wife's side. Her father was too. His teachers say he often writes with both hands in the same session. I did have a word with his teachers a while back because I was concerned about his spelling. They sent him for tests, and we just had confirmation that he's mildly dyslexic. It's a relief, actually, because now he's getting the support he needs.
Yes, I see. And going back to when he was born, has Tony had any health problems at all?
He arrived late, well past his due date, at over 2 weeks late. and the labour didn't go as planned. My wife was induced, and Tony seemed to react badly to the stuff she was receiving intravenously to bring on labour. In the end, he was born by caesarean because he was in distress. Then he had an infection and needed a course of antibiotics. They began that immediately, and he was on them for 5 days. They both had to stay in hospital because of it. But other than that, he breastfed well and was a happy baby, even if he did have a touch of jaundice. That soon disappeared without any need for further intervention.
Mm-hmm. I see. And there's been nothing of note since then?
Well, there is one thing. About a month after his first birthday, Tony came down with a bad virus. He had a high temperature of about 40 degrees. Mm-hmm. That brought on a febrile seizure. It was so scary. But it only lasted about 5 minutes, and then he seemed to be back to his normal self. That's the only one he's had.
Right. Is there anything in his family history I should be aware of?
Nothing of note, no. My wife's parents are Chinese, so Tony's learned both languages from when he was a baby. Mm-hmm. I don't know if that has a bearing on anything. His grandparents are all fit and well. In fact, relatives on both sides of the family seem to die of old age.
Right.
Though maybe I should mention that my wife does get sciatica from time to time. She hasn't had it for ages, but when she does, she can be out of action for weeks.
OK. Well, thank you for filling me in on all of...
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a dentist talking to a trainee dental nurse. Now read the question.
One of your responsibilities is to maintain moisture control for the patient using a device called the oral evacuator, which sucks up excess moisture and debris from the oral cavity.
Okay.
Now, when you're evacuating in the front of the mouth, you may notice saliva building up further back. But you don't take the evacuator tip and put it straight down in the center of the throat because this can activate the gag reflex if you touch the soft palate. So use it in the corners, and you don't want to press against the soft tissue of the cheek either. That can cause injury.
Right.
You should also pay attention to the patient's body language. If you see any signs of anxiety in the eyes or in the hands, you may want to ask if everything's all right. Mm-hmm. It's a way of alerting the dentist, too.
Question 26. You hear 2 nurses in a GP surgery discussing a case of chickenpox. Now read the question.
Did you see Mr. Henson and his baby when he brought her into the clinic? She was absolutely covered in a rash.
Yeah, it did look bad, I suppose. You can understand why he and his wife were so worried when they first noticed it. But it was just a classic case of chickenpox.
Those blister-like spots confirmed it. He's had the illness himself, but as an infant, so I guess he didn't recognise it. Let's hope nobody else in the waiting room's picked it up.
Well, it'd certainly be worth keeping her away from other people for a bit. I don't like the idea of people coming into the clinic getting infected. Anyway, hopefully his wife won't go down with it. Or there could be problems looking after the baby.
Oh, she's already had it. He did volunteer that information.
Question 27. You hear an anaesthetist talking to a patient. Now read the question.
Mr. Clark, I believe the surgeon's already had a word with you regarding the operation and he's outlined the main issues. If necessary, he can go into more detail with you.
I think I'm pretty clear on things now, thanks.
OK. I understand that you've provided a list of medication that you're currently taking, and you know you shouldn't take them on the day of the operation. You seemed anxious about that.
Oh, I was just checking. It makes sense to me, actually.
Good. You had minor surgery last year and didn't respond well to the anaesthetic, I believe.
A bit of nausea, yes, but it didn't last too long.
That's good. But it's still important to know because it affects the type of anaesthetic we give you. We don't want you to have the same experience again.
Question 28. You hear a woman telling a practice nurse about her son's ear condition. Now read the question.
So, how's little Ben been coping with his ear infections?
He's still having them regularly. They're really dragging him down. He's very pale these days and rather tired. I'm not sure if he's suffering from hearing loss, though, but it's hard to tell.
He does look pale. He's 3 now, isn't he?
That's right. He's had this problem for ages, and each time the infection flares up, it's clearly painful. But I think what he's been given really isn't doing him any good. His stomach's upset whenever he has a new lot of antibiotics. And I feel he needs another solution. You mentioned him having an operation. It's not without risks, I know, but I'd definitely be in favour if that would do the trick.
Well, I think Ben should see the doctor again. I agree this has gone on quite long enough.
Question 29. You hear an ear, nose and throat ENT consultant describing a recent cancer case he was involved in. Now read the question.
So, generally, we can say that the treatment on this patient was successful. However, one issue that did arise from this case was the events that made it necessary for us to operate on his nose twice. Now, with a tumor of this type, it's very common for bone erosion to occur. As the tumor shrinks, we often see some degree of CSF leakage, cerebral spinal fluid. We'd expect to see this soon after treatment of the tumor, but with this case, it occurred 13 months later. So we had to carry out a second operation to address the problem. What we've learned from this is that we need to take early bone imaging to see if there are any areas of bone thinning, and then adjust our method of treatment if necessary.
Question 30. You hear a surgeon and an anaesthetist briefing their team before an operation. Now read the question.
The last case on our list is Jonathan. We're going to do a Kelly's procedure on him to rearrange the tissues of the pelvis. You might remember that he had his back done just a few weeks ago. He's had recurrent UTIs as well as respiratory infections. We have some concerns about his chest. His bloods are all normal, apart from his clotting, but he's got 2 units cross-matched just in case. Laurel?
Thank you. It's quite a complex case, anesthetically speaking. He's very wheezy and at high risk of developing a significant post-op chest infection. That isn't going to make analgesia as straightforward as we'd like afterwards. He's going to need a chest x-ray. Oh, also because of his back surgery, he can't have an epidural, which we'd like to have done. We're definitely going to need a bed in intensive care. Perhaps we should call to confirm there's still one available?
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear an interview with Dr. Pauline Lee about her research into the nature of pain. You now have 90 seconds to read questions 31 to 36.
Hello, today I'm with Dr. Pauline Lee, who's looking into the nature of pain, particularly chronic pain. Dr. Lee, can you tell us a little bit about your work?
Well, I'm part of a team which is studying particular aspects of chronic pain. So, for example, patients with irritable bowel syndrome have gut pain. Patients with fibromyalgia will tell you they feel bruised all over, and so on. The thing that underlies these different examples of chronic pain reported by patients is that there isn't any disease process that can account for them. So we think possibly something in the brain may have gone wrong, and that's what we're trying to find out.
So what do we know about the nature of pain?
There's a very famous experiment that was carried out about 20 years ago, where 2 researchers sat in a hospital emergency department and just asked people as they were coming in, "Are you in pain?" Mm-hmm. And what they found was that in about 40% of cases, people said, "No, there's no pain at all," when actually they had pretty nasty injuries. And in about 40% of cases, people reported perhaps rather more pain than you'd expect for someone in their condition, which left only 20% of people reporting the amount of pain you'd expect for their injury. So pain's not a simple matter. There seem to be a lot of different factors involved.
And there are some people who have a congenital insensitivity to pain, which, actually seems like it'd be quite a good thing to have.
Yeah, you'd think a pain-free life would be a good life, but it can have quite serious problems. For example, if most of us have a sprained ankle, it'll hurt. So we won't carry on walking on it. We'll rest it and give the soft tissues a chance to get better.
So pain has a very obvious protective function. But also our sensitivity to pain means there are these little movements that we make all the time, whether we're standing or sitting or whatever, and this is basically so that we don't put too much pressure on one joint. And what happens to the people who don't feel pain and don't make those movements is that blood gets trapped in the joints. It pools there, which means bacteria can multiply in there, and this can do serious damage.
So is there anything that can be done to help people who are unable to feel pain?
It's actually remarkably difficult because if these people do something that's damaging, like pick up a hot dish with their bare hands, they just don't feel it.
Mm-hmm.
They haven't developed the sort of immediate responses that other people develop very early on. It's hot, don't touch it. It appears that if the nerves responsible for transmitting information about pain aren't functioning as they should, it's actually very hard to teach yourself to keep away from the kinds of things that might harm you.
Right, so let's move on to your own research. I understand you and your team are trying to track what happens in the brains of volunteers when they experience pain.
Yes. We decided to use brain imaging techniques to try to track what happens in the brains of volunteers when we make them experience pain without receiving a direct stimulus to any part of their body, so with no direct contact at all. And we've found we can create pain by hypnosis, for example. And we've shown the volunteers pictures of people with injuries, and we've used a rubber arm illusion where you give them a fake limb and then stick a pin in that limb. And in this way, we're building a picture of what the brain does when it creates an experience of pain in the absence of an actual tactile stimulus.
Interesting. And are there any other developments that you're involved in?
One new development which I've been a part of is that we tend to associate pain with a smack in the face or a cut to the wrist. But increasingly, we've come to understand that in a fair proportion of people, when they observe someone else in pain, it triggers an experience of pain in them too.
Right.
Anecdotally, I've done quite a lot of work with back pain patients, and we've noticed that when they see someone else doing a bad lift or a bad bend, they'll wince and they'll say, "Yeah, that hurts my back." So we're thinking that if we can start to understand the different avenues that create pain, we can perhaps give better education and better treatment to our patients.
Dr. Lee, thank you very much.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a presentation by an orthopaedic specialist called John Bevan, in which he describes the case of Lucy, a patient with osteoporosis. You now have 90 seconds to read questions 37 to 42.
Hello, my name's John Bevan and I'm an orthopaedic specialist. I'd like to talk to you about a patient of mine with osteoporosis. I'll call her Lucy. The story begins 2 years ago when Lucy went to see her GP. Lucy had recently given birth to her first child at the age of 34. The pregnancy was normal, the baby girl was healthy, and Lucy seemed to be coping well. But then Lucy started to get sharp twinges, particularly in her back, and she felt deeply fatigued. Her partner suggested she saw a doctor, but Lucy thought it might just be some new mum problem and did nothing for a while. What eventually prompted her to seek help was a sense that her entire posture seemed different, that her shoulders were much narrower than before, that her clothes were all too large. Lucy's GP said she was displaying classic post-pregnancy symptoms and recommended she rest and make the most of any help she could get with her baby and the housework. A perfectly logical response. When she asked if she could be checked by a specialist, her GP said they should see how things developed, but he did prescribe some painkillers for her. Again, not unreasonable at all. One thing he didn't do, according to Lucy, which could be regarded as a missed opportunity, was spend much time delving into the details of how she was feeling and her background. Whatever demands GPs face, certain things are simply good practice. 2 months after she'd started to feel unwell, Lucy was referred to my clinic. The first time I met her, she was clearly distressed. She had tried to carry on doing as much as possible, carrying her baby, some light housework and shopping, but could hardly do anything because of the pain. Her partner ended up doing everything, and she felt embarrassed that she couldn't look after her baby. I think this feeling was particularly acute because she obviously knew what was required and what it felt like to be strong and fit. She'd been a keen runner, careful about her diet, and rarely drank any alcohol. But I also discovered that her mother, who died a few years before, had suffered from osteoporosis. This was something she hadn't previously mentioned. After carrying out various tests, I recommended that Lucy should have back surgery. The test showed she had 2 fractured vertebrae and Cushing's disease, with osteoporosis as a probable secondary complication. Cushing's disease is caused by a benign tumour in the pituitary gland, which produces too much cortisol. This affects the bones and prevents absorption of calcium, leading to osteoporosis. We opted for a balloon kyphoplasty, a form of surgery in which a small balloon is inserted into the spine and used to push the fractured bones back into place. The advantage of this procedure was that it would provide almost immediate pain relief, which would enable Lucy to face up to the other treatment she required. The alternative involved bed rest, painkillers, and physiotherapy. This could have worked, but it would have been much more drawn out. The back procedure went well. Removing the tumour leaves the body with low cortisol levels, and Lucy has to take hydrocortisone to compensate. But crucially, the back pain has gone. So, what now? And what are Lucy's prospects? She's taking a bisphosphonate with calcium and vitamin D supplements for her bones. She's also doing weight-bearing exercises to improve her bone density, as many osteoporosis sufferers do. I see no reason why, eventually, she shouldn't be able to do everything she used to. Given the impact of the tumour and the likelihood of hereditary osteoporosis, though, she probably won't come off the drugs for several years. Osteoporosis hits many women hard when they reach the menopause, but if we monitor Lucy, I don't see why that should be a major issue for her. So, what can we take from Lucy's story? It's well known that osteoporosis is one of those conditions that people think will never happen to them, even though 2 out of 5 women are likely to get it. The information's out there, but it's almost as if people choose not to listen. What's striking about Lucy is that she's still only in her 30s. There's a tendency to assume it only affects a certain demographic, and that's by no means the case. On the plus side, there have been exciting developments regarding what we know about the condition and how we can deal with it. In the next 10 years, there may well be drugs that can reverse the pathology much more effectively than is currently possible.
That is the end of Part C. You now have 2 minutes to check your answers.